Hello, everyone. Welcome to our Core Kidney Grand Rounds webinar. My name is Alicia Chowdhury, and I am the co-president of the Bruin Beans Health Club.
Hello, everyone. My name is Arif Tendon, a fellow co-president of the Broom Beans Health Club. Broom Beans is in the undergraduate division of core kidney and is composed of UCLA undergraduates who work alongside nephrologists to bridge the gap of misinformation around kidney health and to grow awareness, community knowledge, and the body of research on kidney disease. We follow the core values of clinical excellence, outreach, education, and research. We're grateful to Dr. Stogie and the core kidney team for having us on. And next, I would like to introduce Ashley.
Hi everyone, my name is Ashley and I am the Core Kidney Patient Events Coordinator.
This webinar is an example of outreach we conduct under Dr. Rastogi. He has taught us how to build the bridges between the clinical world and the lived experiences of patients. We will now pass it off to Dr. Rastogi to introduce our presenter for today.
Great. Thank you. Thank you, Alicia. Thank you, Ara. Thank you, Ashley. And thank you, everybody, for attending, and also those who can't attend in live. This will be recorded and we posted. My name is Anjay Rastogi. I'm the director of the Core Kidney Program at UCLA Health. And today it's my real pleasure to introduce my colleague, but more importantly, my dear friend, Dr. Johnathan Zuckerman. He is a service chief of renal pathology at UCLA. Now, I've spoken multiple times on the role of the pathologist in the care. The patients don't directly interact with the pathologist, but they can have a significant impact on the care a patient receives. And I said they can is because they need to be more involved and get more involved. Now, Dr. Zuckerman is heavily involved. He teaches us, he educates us, but also listens to us about the cases, the case history, and then gives us feedback on what he thinks from what he sees under the microscope, what we should be doing. So the input of individuals like Dr. Zuckerman is very, very important in the care that we provide to our patients. Now, I had asked Dr. Zuckerman to speak on podocytes. And this is in follow-up that a presentation that he had given, and I found that extremely useful. And to myself as well, I learned so much. So Dr. Zuckerman will be speaking about podocytes, but also specifically as they apply to minimal change disease and FSGS, which are podocyte disorders. So with that, I'm going to hand it over to Dr. Zuckerman. We will have a Q&A at the end. If you have any questions, please put them in the chat. I will be asking those that at the end of the presentation. Thank you very much.
Well, thank you, Dr. Rastogi, for that wonderful introduction. And it's really a pleasure for me to be here this afternoon to talk to you guys all about the pathology of podocytopathies, really focusing in on the diseases that are primary podocytopathies, being minimal change and FSGS, in my opinion and perspective on these specific diagnoses. So I find it helpful when we're talking about pathology and diagnoses to really frame everything in the setting of clinical, real clinical cases, and how we sort of think through such cases. So we'll start with our first example case. And this is a 10-year-old boy who presented with foamy urine and generalized swelling for about 3 weeks. Otherwise, he was normal up until about 3 months ago. Serum creatinine was 0.92 milligram per deciliter. He had low albumin at 1.6 grams per deciliter, and he had very high proteinuria with a urine protein creatinine ratio of 11.4. And he had an autoimmune and infectious serologic workup that was negative. And so this is a person who's presenting with nephrotic syndrome, edema greater than 3 grams of protein per day, and low albumin. So a biopsy was pursued to further investigate the reason for this patient's nephrotic syndrome. And we start with a light microscopic examination. We look at the glomeruli. We can see that they're essentially normal with open capillary loops, delicate walls of the capillary loops. The urinary space is patent. The mesangial regions are normal. Looking out in the tubular interstitium, essentially we have tubules that are back-to-back with no intervening fibrosis or inflammation, and there's no evidence of any inflammatory lesions in the glomeruli, such as necrosis or crescents. Then we looked at our immunofluorescence, which is something we do for all native kidney biopsies. And we saw something interesting. So on the stain for IgG immunoglobulin, we see that there's this granular staining sort of out in the urinary space that seems to follow the distribution of podocyte cell bodies. This has been described as dusting of the podocytes with IgG. And it's a relatively newly recognized immunofluorescence pattern that we'll talk some more about. And we can see as compared to our background tissue control albumin, we don't see that in the albumin. So this seems to be specific IgG staining on the podocyte cell body. Then we look at our electron microscopy studies, which is something we do in renal pathology because it gives us very fine granular detail on the disease processes. And here we can see two glomerular capillary loops. This is the blood space. This is the urinary space. This is the basement membrane. This is the endothelial cell. And normally on the urinary space side of the basement membrane, there should be these well-formed podocyte foot processes, sort of these little structures here on this example of normal. But instead, what we see is essentially flat cytoplasm covering the urinary space side of the basement membrane. So these are those foot processes, but they're just very widened and spread out. We call that effacement of the foot processes. So it's evidence of podocyte injury. In other areas, if we zoom out a little bit, this is the podocyte cell body. You can see it's putting down its processes to become the foot processes here and here. The cell body itself does not look normal. We can see that there are these little finger-like projections coming off of the podocyte cytoplasm. We call that microvillus transformation. It's another feature of podocyte injury. And then we can also see some vacuolization of this podocyte cell body's cytoplasm. So the podocytes seem extremely injured. So to summarize, this biopsy is showing features of a podocytopathy. The light microscopy doesn't show any real significant pathologic changes, but the EM shows us those features of podocyte injury, which I had shown you. And then the immunofluorescence is showing this punctate IgG podocyte cytoplasmic staining. So can we understand what is happening in this biopsy and why? So let's take a step back and talk a little bit more generally about podocytes. So podocytes are highly differentiated post-mitotic cells with limited regenerative capacity in adults. They line the outer aspect of the glomerular basement membrane and form the final barrier to protein loss. So in this cartoon, we have a glomerulus here, we have capillary loops, and the podocytes are these blue cells here that line the external surface or the urinary space surface of the capillary loops. And in that EM-like cross-section, you can see they have these little foot processes that line the basement membrane. If we look at that in 3 dimensions, we can see that the foot processes come off of the podocyte cell body as they sort of wraps around the capillaries and form this interdigitating network that when we cut in cross-section in a line like that, we get what appears to be little foot processes, which are actually quite long cell processes. And we can actually visualize this by scanning electron microscopy here, where we see podocyte cell bodies, and then we see the processes, and then you can see the interdigitation of the foot processes. This really delicate, well-organized cellular structures. So what is a podocytopathy? So podocytopathies are kidney diseases in which direct or indirect podocyte injury drives the clinical presentation of the proteinuria or the nephrotic syndrome. And so what does an injured podocyte look like? Here's our healthy podocyte here. As I already showed you, you can get effacement, so loss of that podocyte foot process. This is in 2 dimensions, sort of in 3 dimensions. You can see sort of a normal interdigitating podocyte foot process network here. And then in states of injury, you can see those foot processes widening out and becoming very, very flat and wide. Additionally, you can see cyst formation or pseudocyst formation. The podocytes can denude from the basement membrane. You can get increased lysosomes as well as shedding of cellular elements in that microvillus transformation. We saw all of that by electron microscopy. Additionally, podocytes can respond to stress sometimes by undergoing mitosis, which is a catastrophe because even the podocyte can duplicate its nucleus. It can't actually undergo the full mitosis and can't actually divide. And so this is sort of a terminal event for that podocyte. So the physiologic consequence of podocyte injury is proteinuria. And so why do we get heavy proteinuria in the setting of a podocyte injury? So if we imagine the normal filtration barrier here, these are the foot processes, this is the basement membrane, this is the endothelial cell, and this is the blood space. Under normal physiologic pressures, there's enough, the flow rate through the slit diaphragms is sufficiently gentle such that the negatively charged albumin in the blood is reflected by the negative charges on the endothelial cell, because the albumin is actually small enough to get filtered if it wasn't for the negative charge on the endothelium. But if you injure a podocyte, what happens is those little slit diaphragms, the end of the filtration barrier, gets enlarged. Those spaces widen. And the areas between those widened slit diaphragms, the foot process, areas with foot process of the basement, essentially completely cover the basement membrane, limiting filtration. So in the injury state, rather than having sort of a nice gentle flow, like a gentle sprinkler that's going back and forth, you get these garden hose-like jets of fluid through the abnormal slit diaphragms. And there's enough hydraulic conductivity then to pull the albumin through the filtration barrier, overcoming that electrostatic repulsion that is seen under normal physiologic consequences. In addition, these changes in podocyte structure affect the compression of the basement membrane, which also can make it more leaky. There may be changes in the charge of the basement membrane. So this is one theory. There may be other mechanisms that also drive the proteinuria. So what actually causes injury to podocytes? Many things. So there are circulating factors like cytokines, podocyte autoantibodies, various drugs, medications, viral infections, shear stress, ischemic injury, genetic problems, glomerular inflammation, and a variety of other systemic disorders. So we divide podocytopathies into a few large, kind of clunky buckets to conceptualize underlying etiologies. And mostly what this, or at least the first part of this talk is focused on are things we call primary podocytopathies. So these are due to presumed circulating factors, autoantibodies or cytokines or other factors we have yet to identify that are made in the body and directly injure the podocyte. But you can get podocyte injury due to what we call secondary etiologies, which are sort of maladaptive, drug-induced viral, prior glomerular inflammation, genetics, and sometimes we really are not sure, so it's sort of a wastebasket, sort of unknown category. So in our case, is there anything in the biopsy that can tell us why this patient is having a podocytopathy? And there is, in that fine dusting of the podocyte with IgG is actually recognized to be identifying a potentially pathogenic antibody, which in most cases is recognizing a protein called nephrin, which is part of the podocyte slit diaphragms. And it was shown very nicely in the seminal paper that these patients that have a certain type of podocytopathy, minimal change disease, have this, a subset of patients have this dusting in their podocytes, and that co-localizes very nicely with the nephrin protein. And if you look in the blood of these patients, when they have active disease, they have active anti-nephrin antibodies in their blood, suggesting that this abnormal production of anti-nephrin antibodies is driving a subset of podocytopathies. And since that time, there's sort of been an explosion of work in this field, and many other groups have sort of reproduced this finding and found these autoantibodies in a significant subset of minimal changes these patients, as well as primary FSGS, as compared to other glomerular diseases. And they seem to be more prevalent when the patients are nephrotic and have not yet received immunosuppression. And similar results have been produced in animal models as well. And this is in regards to anti-nephrin. Several additional podocyte autoantibodies against other slit diaphragm proteins, such as CURL1 and Podocin, have also been identified and show that similar dusting. So there are multiple potential autoantibodies, although it seems like anti-nephrin is the most common that has emerged. As a side note, this is still a work in progress, and while the field is generally accepting this, I have heard some dissenting voices that suggest that this may still be an epiphenomenon, but at this point, the field is really believing that these are truly pathogenic antibodies. So what happened with our case? So this patient was started on corticosteroids with complete resolution of symptoms and proteinuria within 3 months. So what happened here? So likely this patient had some sort of immunologic underlying autoimmunity resulting in production of autoantibodies to podocytes, resulting in an acute diffuse podocyte injury or podocytopathy. This was a reversible podocyte injury, is that once you stop that immunologic stimulus with your corticosteroids, the podocytes recovered, the patient got better. So this sort of pattern of injury of a normal kidney biopsy with just podocyte injury, typically responsive to steroids, is called minimal change disease, if you want to sort of give a label to it. And I'll sort of talk about why I don't like these labels as we go through this talk. But this is sort of classic for the entity minimal change disease. And so we can think about minimal change disease as a diffuse acute reversible podocytopathy without any irreversible scarring or sclerosis. Now, minimal change disease is a pattern of injury. It may be primary or idiopathic, meaning we don't know exactly why the autoantibodies or cytokines or whatever is driving it form, but it's a purely renal limited disease, but can also be associated with a variety of secondary etiologies such as drugs, lymphoproliferative disorders, bone marrow transplants, some autoimmune diseases, and a subset of vaccination reactions, rare complication. And typically this presents as new onset nephrotic syndrome, although this may relapse, recur in some patients, even very after long periods of time. I recently was doing some research work looking at trying to find patients that adult patients with new onset minimal change disease. And we kept having to eliminate patients from the cohort because they all seem to have some history of a pediatric minimal change disease. So I think late kind of relapses and recurrence are perhaps more common than we recognize. Now, does the dusting of the IgG help you with the etiology? Not necessarily. There's this nice paper from our friends at Cedars-Sinai that looked at that dusting pattern by immunofluorescence in both primary and secondary minimal change disease cases. And you can see the dusting both in the primary and minimal change disease cases associated with those other secondary etiologies. So that doesn't necessarily help you that much, but still a work in progress. So now let's look to some more kind of aggressive disease courses. So what happens if the podocyte injury is prolonged or intrinsically more severe? Well, you get podocyte loss. So you can imagine you have podocyte injury, you get effacement, you have sustained injury, or there's some other second hit, you get irreversible podocyte stress, podocytes die, and you get sclerosis. So let's look at an example of this. This is a 12-year-old with nephrotic syndrome, previously treated with steroids, now is relapsed and steroid resistant. So presumed minimal change disease, never get a biopsy, and then empirically treated, and now they're not responding to steroids anymore. So they got a biopsy, and this is what we see. These glomeruli that have these segmental or portion of the glomeruli that are involved by sclerosis, the capillary loops are closed. They're stuck to Bowman's capsule or adhered to Bowman's capsule, and there's some degree of increased cellularity, these foam cells in the endocapillary spaces. There's a little bit of epithelial cell or the podocyte-derived epithelial cells hypertrophy over some of these loops. So these are segments of sclerosis, so scarring of the glomerulus. If we look at the immunofluorescence, we can see that granular dusting pattern on the podocytes may be a little bit brighter in this example. And now we see some non-specific staining with IgM, which we frequently see in lesions of segmental sclerosis, but no other significant immunofluorescent staining. And then just like the minimal change disease case, we see extensive podocyte process effacement and other features of podocyte injury, such as microvillus transformation and condensation of the podocyte cytofilament network. More microvillus transformation effacement. Looks identical to the minimal change disease case by EM. So what is happening here? This biopsy is showing us features of podocytopathy now with irreversible glomerular scarring, represented by lesions of segmental glomerulosclerosis due to podocyte loss. And the EM is just showing us features of a podocytopathy, just like minimal change. And then we have that same punctate IgG staining of the podocyte cytoplasm. So we can sort of understand the EM and IF findings, but let's understand the light microscopy findings more because it's different in this case. So FSGS, or focal segmental glomerulosclerosis, is a descriptive term for pattern of injury seen by light microscopy. The term focal means there's heterogeneous involvement of the glomerular population within the renal cortex. So less than all of the glomeruli are involved. Typically, we use 50 or more %, but I don't think we need to be so dogmatic, because if we actually we do multiple levels into the block, we really scrutinize the tissue more than we do for a normal clinical read. We can actually find that the lesions are distributed in many more glomeruli than we typically actually evaluate on our clinical studies. Segmental implies that less than the total glomerular volume is involved by the sclerosis. And ultimately, and I'll say this maybe another 4 or 5 times throughout this presentation, the pattern of FSGS, the lesion of FSGS, is just a pattern of injury. You need to integrate the other findings in the biopsy, such as electron microscopy, as well as the clinical information, to come to a more etiologically specific diagnosis. So FSGS, while we do use it as a diagnostic term, is a very imperfect diagnostic term. So consequences of podocyte loss. So when you have that injury, the podocyte can fall off and leaves a bare basement membrane. Sometimes this repairs, and then maybe this is more of a minimal change disease phenotype. But more often than not, if you've lost podocytes, you'll get scar formation, as I've shown you. And typically what happens is the parietal epithelial cell will see this exposed basement membrane. It'll put down some cell processes and sort of tether that capillary loop to Bowman's capsule, cause some profibrotic signaling, cause some abnormal flow, and that sclerosis can propagate into a bigger, true scar over time. And then certainly additional episodes of podocyte loss can worsen that as well. Now, podocytopathies are a spectrum disorder, and the intensity, either the acute severity or the long persistence of injury, defines the histologic reaction and clinical presentation. So the more intense the injury to the podocyte is, sort of the more severe phenotype of sclerosis we see. And the more sclerosis and the more scarring there is, the less steroid sensitive and the likelihood of remission we'll see. And again, this goes along with increased podocyte depletion. In addition to the injury stimulus itself, there's likely a few intrinsic patient risk factors that probably also play a role in this axis as well. But again, I want to emphasize that I believe that minimal change disease and these other sclerosing patterns just really sit on the same spectrum. We're not really talking about 2 different diagnoses here. And in fact, we're probably talking about multiple separate diagnoses based on what's actually causing the injury to the podocyte, with the injury to the podocyte being the main factor rather than the biopsy morphology. And what we can see in animal models is there's actually a number of podocytes that you have to deplete to get lesions of segmental sclerosis. So here they used a toxin-based injury model in an animal to deplete podocytes. And what they saw was about once you get above 20% of podocyte loss, you start to see adhesion, sclerosis, and glomeruli. And that sort of mild loss is associated with persistent low-grade proteinuria. But once you've lost more than 40% of podocytes per glomerulus, you get more severe, persistent, heavy proteinuria and segmental and global scarring. So what happened with our case? The patient was treated, had partial response, but unfortunately went on to develop end-stage kidney disease. So in this case, we likely, again, had an immunologic-related diffuse acute podocyte injury, possibly antinephrin antibodies. It resulted in irreversible podocyte injury represented by the segmental scarring, and the treatment was not effective, either due to the irreversible damage or some recalcitrant nature to whatever the immunologic reaction was that was causing that autoantibody production. And so this clinical pathologic picture, we currently diagnose as idiopathic primary or permeability factor associated FSGS, which we can think about as a diffuse acute podocytopathy with irreversible scarring, classically thought to have a higher chance of disease progression. Now, I really want to drive home this point about minimal change in FSGS and all these podocytopathies being, primary podocytopathies being a spectrum. Because here's what I see when I get a transplant biopsy in one of these patients who had end-stage kidney disease due to primary FSGS, who has a recurrence. So this is a patient who had significant proteinuria several days after they got a transplant. The glomeruli look entirely normal, but then by electron microscopy, we see extensive podocyte foot process effacement, which tells us it was a podocytopathy. So what do we diagnose? This patient has a minimal change disease pattern of injury, but originally we know the patient had a primary FSGS at some point. So clearly this is the earliest phase of FSGS, which is minimal change. So hopefully this illustrates the spectrum of this disease. And really, this dichotomy of minimal change in FSGS, I think, is false. And we're just really looking at a continuum of disease processes mediated by similar mechanisms, just with sort of divergent downstream trajectories, which may or may not have to do with the original etiologies. I said some of this may be patient-derived factors, such as genetic risk factors, things of that nature. So I prefer to think about minimal change in FSGS as just diffuse primary minimal change or primary FSGS as sort of diffuse podocytopathies rather than injury-based diagnoses, sort of labeling a patient with minimal change versus FSGS. It's also worth noting generally recurrence rates of FSGS in the transplant are quite high in patients that have true primary FSGS and genetic and secondary causes are excluded. So this sort of biopsy picture, unfortunately, is not uncommon in patients with true primary FSGS. Now, studying transplant patients with recurrence has also allowed us to learn that there is a circulating factor involved. And these are two very dramatic examples of this, where a patient had recurrent disease, and we can see the proteinuria going up very quickly after biopsy. And the patient wasn't doing well, with this proteinuria. So the decision was made, a very altruistic patient, to say, take my kidney and give it to another patient that doesn't have my disease. And so that's what happened. And they put this patient, retransplanted this kidney to another patient who didn't have primary FSGS. And look, the proteinuria goes away. So within, immediately after transplant, there's no way the patient's already forming an autoantibody, to something in the new transplant. So this tells us there's a pre-existing circulating factor causing the podocytopathy. Here's another similar example, patient with recurrent disease. This was actually kept in the original patient for about 11 weeks, or I'm sorry, about 11 weeks or so, and then they transplanted into another patient. And this patient had already developed FSGS prior, with the first transplant, but we see with extensive foot process effacement, we see that effacement going away over time in the second patient to receive the transplant, and to some degree resolution of some of the more severe looking scarring, at least based on this figure, which is a little bit interesting. So those are kind of discussion regarding kind of primary podocytopathies, but what are sort of the other types of podocyte injury that we can see, and can we identify those on the biopsy? Are there clues that we may be dealing with something other than a primary podocytopathy? And I've already talked about this list. And again, I want to emphasize that the kidney has a limited number of ways it can react to a vast number of injury stimuli, especially podocytopathies, which may be minimal change disease, FSGS, this collapsing glomerulopathy, diffuse mesangial sclerosis, and all these are just lesions, they're not diagnoses. And any of these patterns can be associated with the same genetic disease, or the same pathologic pattern can be associated with many different genetic diseases or treatment responses. And as I said, this is like the 5th time I'm saying this now. You'll read these things in the literature as specific diseases, but they're not. They're patterns of injury. And you really have to put the whole clinical picture together, the whole picture together, both the biopsy findings and the clinical, sometimes genetics, to really make a diagnosis. And so there's no such thing as a standalone diagnosis of biopsy-proven type of podocytopathy. Like there's no such thing as biopsy-proven primary FSGS. Everything needs, or primary minimal change, everything needs to be interpreted in the clinical context. So we do have to be careful. Certainly as a pathologist, I can come to a clinical pathologic diagnosis in my report, but it's not solely based on my biopsy findings. I'm considering the clinical information I've received when I make my reports. And so we can think about some of these different etiologies and clinical pathologic groupings, in the setting of the clinical presentation. So diffuse acquired podocytopathies are typically sudden onset with full nephrotic syndrome. So these are the idiopathic primary podocytopathies I've been talking about. Some viral, drug, and really genetic etiologies can present this way, but it's more unusual. You can have more insidious or focal acquired podocytopathy. So these are more chronic, progressive proteinuric diseases due to sort of secondary etiologies like maladaptive change. Diffuse genetic podocytopathies. So these are early onset nephrotic syndrome, in infants and babies. These are due to catastrophic genetic defects in podocytes. But you can also have insidious or focal genetic podocytopathies. So kind of more slowly progressive, late onset, slowly progressive proteinuria, and age-related penetrant, such as APOL1 nephropathy and a variety of podocyte-related genes, glomerular basement membrane diseases, and just realize that some of these patterns may be mixed, and you can't always pigeonhole individual patients to a single one of these categories, as there may be diffuse acquired podocytopathy superimposed on underlying genetic risk factor, let's say, or maladaptive secondary FSGS superimposed on a call4 abnormality or something like that. So we have to keep our mind open that patients may have more than one etiology for their podocytopathy that we see on biopsy. So how can we use this combination of clinical features and biopsy findings to kind of help, to the best of our ability, segregate our patients into sort of useful clinical heuristics to better guide our treatment? So in regards to primary circulating factor associated podocytopathies, if we have sudden onset new and full nephrotic syndrome, or relatively recent onset new nephrotic syndrome, less chronic changes in the biopsy, and extensive, more than 80% foot process effacement, in this we can pretty much consider to be primary FSGS. Now, if we have subnephrotic range proteinuria or nephrotic range proteinuria without full nephrotic syndrome, so normal or minimally low albumin without edema, more chronic changes in large glomeruli, and importantly segmental, so less than complete foot process effacement, more likely to be secondary maladaptive type injury. Then when we get into genetic or drugs, these are much more variable presentation, and we would need to sort of have a history of drug or viral infection, and genetics we may expect based on the age of the patient, and some features like extensive foot process effacement despite non-nephrotic range proteinuria. But these are more difficult to identify in biopsy. Typically, we're trying to differentiate primary versus maladaptive, I would say, in the vast majority of our biopsies. So let's look at an example of one of these sort of maladaptive secondary FSGSs. This is a 54-year-old man found to have about 3 grams of proteinuria, some mild hematuria as well, normal renal function otherwise. He has BMI of 35 and hypertension. No other prior medical issues, and autoimmune and infectious workups were negative. And so we go to biopsy, and this is what we see. So this is the full tissue corner. You can see this glomerulus is almost the entire width of the tissue course, the entire width of this 18-gauge needle. So that's pretty big. So this is a large glomerulus. So we call that glomerulomegaly. And if we look in the hilar region of this glomerulus, so here's the afferent and efferent arterioles, we can see that there's this area of more pink color. There's consolidation and sclerosis of the capillary loops involving the hilum. So this is a what we call perihilar type segment of sclerosis, or sclerosis that sort of interacts with, involves, or begins at the hilum. The immunofluorescence in this case just showed us nonspecific trapping with IgM. The rest of it was negative. And then on electron microscopy, we can see that the foot processes are more intact. We can see some intact foot processes here and here. There's maybe some partial effacement in places. Maybe there's a little bit of microvillus transformation, but there's not this extensive effacement involving most surface areas. Additionally, if we go and measure the glomerular basement membranes, are also a little bit thin. So depending on the lab and the sex of the patient, anything under about 215 nanometers by direct measurement is thin. So here we have measurements from 129 to 189 nanometers. So that's a bit thin, which is may mean there's something else going on here besides some sort of maladaptive glomerular injury. So what is this? How do we put this biopsy together? So we have evidence of an adaptive or maladaptive glomerular change. It's sort of the glomerulus is getting big, probably in response to the patient's elevated body mass index, where there's increased blood volume and hyperfiltration of the glomeruli to compensate for those physiologic changes of elevated body weight. And we see that there's patchy foot process effacement, so it's not a diffuse podocytopathy, and we see thin glomerular basement membrane, so maybe there's a possible genetic component to this as well, which could also explain the patient's hematuria. The clinical picture was slow, gradual onset of proteinuria without bona fide nephrotic syndrome. So likely what we're seeing here is long-term shear stress of the podocyte due to this glomerular hypertrophy, causing hyperfiltration and mechanical stress on the podocyte, resulting in partial podocyte cell injury and cell death in a much more slow fashion than those massive primary podocytopathies. But still, we get irreversible glomerular scarring over time. And so this would be an example of an insidious or focal acquired podocytopathy, and possibly with or an insidious focal genetic podocytopathy. And when we see this paravidry on a biopsy, I will typically just top-line diagnose something like this as secondary FSGS, to make it clear that this is not a patient that needs immunomodulation to manage their proteinuria and symptoms. Now, I also want to emphasize that proteinuria and podocyte injury may precede the development of detectable FSGS lesions on a biopsy in some of these secondary FSGS situations, especially with maladaptive glomerular injury. And this was some seminal work looking at obesity-related glomerulopathy, showing that patients with elevated body mass index can have enlarged glomeruli, so these black squares here versus normal age-matched control here. But what they found is that, a subset of patients had obesity-related glomerulopathy, and a subset, and these were without lesions of FSGS, and then a subset of patients also had lesions of FSGS, and what you can see is the proteinuria amongst, whether it was non-nephrotic or nephrotic, was the same amongst both groups. And so what this tells us is that it's this shear stress in and of itself, the maladaptive injury, even without sufficient podocyte loss to result in scarring, can still result in proteinuria. So even if you don't have FSGS lesion on the biopsy, if the glomeruli enlarged, the biopsy for a patient with elevated body mass index, we may still be able to explain proteinuria even without segmental scarring. So I've seen sometimes in reports people say, can't exclude unsampled secondary FSGS. I think that's sometimes a little bit silly, because there's other factors other than seeing that lesion which may be responsible for the proteinuria. So this case brought up a potential genetic issue. So when do we pursue genetic testing in such patients? And this is mainly for adult patients. If you have the clinical syndrome, nephrotic syndrome plus diffuse foot process effacement, essentially you can treat empirically. If there's response, we assume this is primary FSGS. If there's treatment resistance, genetic testing is probably indicated. No nephrotic syndrome, extensive foot process effacement, genetic testing. Segmental foot process effacement, no nephrotic syndrome or proteinuria, and the patient doesn't have clear secondary etiologies for this segmental scarring, genetic testing is worthwhile. But if you can explain the secondary FSGS, clinically, probably can hold off on genetic testing. And again, genetic testing also is based on whether or not that's going to affect your management. And while in some cases it may not affect management now, as there are many trials coming up for a variety, even genetic etiologies for FSGS, knowing that etiology may make that patient eligible for a clinical trial. So I do think this is worthwhile, and genetic testing is becoming much more available these days. I think there should be a low threshold. And what we see, and this was, I believe, studied by Mayo group, is at least out of 49 patients with FSGS lesions, if you really stratify them based on that clinical pathologic table I showed you, those that have sort of the clinical pathologic primary FSGS very rarely have genetic abnormalities. Those that have the clinical pathologic phenotype of the secondary FSGS maybe slightly more often have genetic abnormalities, but where you really see positive genetic testing is in patients who have the phenotype of secondary FSGS without a clear clinical cause, and those that have a mixed phenotype where we can't really figure out what's going on. Oftentimes those have a high rate of a positive genetic test. So in the last part of this talk, I'll talk about, are there biopsy features in podocytopathies that can predict outcome in response to treatment? And this gets us into the discussion of something that's called the Columbia classification of FSGS lesion. This is a major working classification that recognizes 5 histologic variants of FSGS. This is applied to any FSGS lesion regardless of etiology, and this doesn't help us differentiate primary versus secondary versus any other etiology. I've listed them out here. And I'll talk about the morphology as it becomes germane. But your pathologist should know the system, and you as a nephrologist, or other clinician, mainly I want you to focus on the collapsing variant and tip variant. Because if we look at outcomes, and this is sort of all comers of FSGS, this is probably a mixture of primary, secondary, and genetic FSGSs. And what we can see is that tip variant does the best overall, and collapsing does the worst. And this has sort of been confirmed in multiple studies. The problem is that this is useful sort of looking at populations. For your patient or you personally is less useful, because as we can see, if we look at complete and partial responses, there are collapsing cases that respond, and there's tip variants that go on to end-stage kidney disease. So even though on a whole, one may be bad and one may be better, it doesn't necessarily predict for your particular patient their progression. Ultimately, clinically, are they responding to treatment? I think more so than what the pattern of injury is in their biopsy. It's also worth noting that a lot of the seminal studies looking at collapsing had patients of African ancestry in their groups, and overrepresenting in the collapsing lesions, which likely represents a certain genetic predisposition, which we'll talk about in a second, which also colors a lot of these data. As a pathologist, I also find the classification system actually not as straightforward to apply. If you're really looking at every level of every biopsy and following the glomeruli, some lesions can be ambiguous, like is this a tip lesion or is this a collapsing lesion? There's a variety of sampling bias depending on which level of the biopsy you look at. These may change over time with the disease course. As I said, the FSGS lesions doesn't take into account anything about the etiology, the degree of foot process effacement, and a lot of the data regarding the morphology to outcome correlations are also colored by other chronic changes in the biopsy, such as global sclerosis and IFTA, since tip variants also frequently show less global sclerosis and interstitial fibrosis, tubular atrophy, cortical scarring, where oftentimes the collapsing variants show more global sclerosis and interstitial fibrosis and tubular atrophy. So, for some of these collapsing cases, are we just looking at a later time point? We didn't capture the disease soon enough versus the tip variant. And again, we lost the validation studies often lack genetic analysis. So how do I use the Columbia classification in my practice? I do think identifying tip variant versus collapsing is useful. Tip variant is typically more benign and sort of implies a very segmental injury to the podocytes right at the tip most, because there's a heavy concentration of protein that's directly injuring those podocytes, which is slightly different from the injury affecting the podocytes globally in that setting. So it may imply something about the pathogenesis of that lesion. And with collapsing, I note it less for its poor prognostic significance, but more so because it engenders an additional differential diagnosis that we need to think about, and I'll talk about that on the next slide. I also typically note perihilar variants. So this is mostly seen with the maladaptive and secondary type FSGS, but not entirely. And just of note, there are some reports where they looked at the native kidney and the transplant kidney with recurrence and showed similar morphology or fidelity of the FSGS lesions. Again, this work has not been well reproduced, but it is oftentimes quoted. So I do want to show you the collapsing lesion here. It's a very unique looking lesion where the capillary loops are sort of compressed or they're imploded, and the overlying epithelial cells are markedly enlarged, hypertrophied, and proliferative, hyperplastic. And we see these large pink globules, protein resorption droplets within the podocyte or the epithelial cell cytoplasm. Here's another example. The capillary loops are just compressed with this overlying cellular hypertrophy and proliferation. And then over time, as the lesion becomes more chronic, it just sort of kind of collapses in on itself. And it's a little harder to distinguish from other morphologies of FSGS. So when we see this pattern, we have to think about some specific differentials, mainly viral infections, HIV, COVID, B19, which may be driving podocyte injury and can look like this. And really what we want to think about is APOL1 risk alleles, since a lot of even in the viral situations, oftentimes that's in the setting of patients who have APOL1 high risk alleles. There's other drugs like bisphosphonates, interferon, and other genetic etiologies, as well as ischemia that can cause this pattern of injury. So again, we have to think about a differential, but the main issues I think here are kind of virus and APOL1 nephropathy. And I won't go too much in here, but APOL1 is a gene which when has a high risk variant, usually either both homozygous risk alleles can essentially form ion channels in the cell membrane and the mitochondria, as well as cause misfolding in the endoplasmic reticulum, and ultimately result in cell damage. And this protein seems to be upregulated in states of elevated interferons, as well as tumor necrosis factors, which may be induced by viral malignancies, autoimmune processes, and certain drugs that ultimately result in injury to the podocyte. It's also worth noting that many collapsing FSGS cases are APOL1 nephropathy, but not all APOL1 nephropathies are collapsing glomerulopathies. Some of them can present as a much more insidious kind of chronic kidney disease presentation. And as we've studied this more and more, we're also realizing that sort of FSGS versus minimal change disease is also not necessarily the be-all end-all of predictions and biopsies, is that if we look at many other morphologies, as was done in the Neptune study here, many other biopsy features, sort of in an agnostic fashion, just sort of noting the presence of the features and then trying to correlate that with how the patients, what the outcome looked like. We can see clustering with certain features in the biopsy with outcome, but we can see if we just look at the minimal change versus FSGS, the outcomes in the X, Y, and Z groups, which are the best, intermediate, and worst outcomes, that there's a lot of crossover between the different FSGS and minimal change morphology. So there may be other factors that we should be considering in our biopsies. Right now, we're not sure how to apply this because this maybe is not practical for daily clinical use, but maybe with computational tools, AI, et cetera, this may be more possible. Similar studies have been done by a lot of the same authors, looking at electron microscopy findings and sort of clustering patients with podocytopathies into different outcome clusters based on the electron microscopy findings. And then lastly, I just want to touch upon congenital nephrotic syndrome for completeness. This was an interesting example of a patient with nephrotic syndrome since birth, ended up having bilateral nephrectomies to make room for the transplant they got. This patient had Finnish type congenital nephrotic syndrome. This was the excision specimen where we have these classic proximal tubule or dilated sort of microcystic proximal tubular changes, and the glomeruli show mesangial hypercellularity and some of these kind of collapsing type pseudocrescent-like lesions. And by electron microscopy, we have extensive foot process effacement. We have some blebbing of the endothelial cell. And then if we look at the slit diaphragms, or where there should be slit diaphragms, there's no slit diaphragms. We have foot processes, but we have these wide spaces, and there's no well-formed foot diaphragms since the mutation these patients have affects a key slit diaphragm protein. So congenital infantile nephrotic syndrome or diffuse genetic podocytopathies. This is nephrotic syndrome in the first year of life. And at this point, genetics testing should be standard for these patients. I don't think I've ever seen a biopsy for a patient like this, albeit these are rare disorders. The one thing to note is that most situations of genetic podocytopathies do not recur in the transplant. Some of these patients may have recurrent FSGS due to development of autoantibodies against the normal variant of their podocyte proteins when they do get a transplant. So something to be mindful of. It's not recurrent to the original disease. It's an alloimmune phenomenon, essentially. And there's a variety of different genes that are responsible for these congenital podocytopathies. Some of the most well-known, MPSH1, MPSH2, LAMB2, and WT1. There's other non-genetic causes that are much more rare in the congenital setting, often congenital infections, but things like primary minimal change or FSGS, within at infancy, first year of life, very unusual. So with that, I thank you for your attention. I'll leave you with a few take-home points here on the screen, and happy to take questions.
All right. Thank you. Thank you, Dr. Zuckerman. That was outstanding. As we had expected, we do have quite a few questions in the chat. I don't know if you want me to read them or you want to read them yourself.
Sure, we can just sort of go through one by one. Okay, so the first question, antinephrin antibodies have been seen in both minimal change and primary FSGS, though less commonly. Do you think that in the future, these two clinical different diseases may be bundled under the same umbrella, just with a different histologic pattern of injury, same spectrum? Yeah, I mean, in my opinion, yes, I do think, especially if you are proving that the antinephrin or anticural or whatever antibody is driving the pathogenesis, it's the same disease, and it's just, is there something about the level of the immune response, something about intrinsic to the patient's podocytes, or maybe another genetic risk factor that is just not picked up yet that causes, one patient to develop FSGS versus another, or, just like their podocyte reserve, total nephron number at birth, something like that. So yes, I do think in many situations we'll consider them the same disease. I don't even now, I don't like to dichotomize them because right now the treatments are kind of, at least by KDIGO, the treatments are quite similar. If you're starting off with minimal change disease, and you then move into the FSGS route if it becomes treatment recalcitrant anyway. So I don't really see much of a difference in really, how many levels I'm going to cut in the block and really trying to find that FSGS lesion. Although it can be important these days for getting into trials, because if you need that FSGS diagnosis, then I need to find that FSGS lesion, even if the patient, is a recalcitrant minimal change disease case.
By the way, I do agree, Dr. Zuckerman, all that you said, and that's a great point that was made by Aditya.
Yep. All right, and then let's see. First question: in patients with FSGS, what histological molecular features currently provide the strongest evidence for predicting responsiveness to immunosuppressive therapy? I don't know much about the, in terms of predicting response to therapy. I think from the biopsy, I think it's challenging. I've sort of presented some data regarding kind of patterns of injury, but I think for your specific patient, certainly collapsing versus tip, you could sort of predict that one will do better than the other. But honestly, I don't think that's the best predictor. And right now,
yeah.
I showed you some of those data from the Neptune study. I mean, there may be other things. It's just not standard practice to put those in biopsy reports. So I can't speak too much to that. And then molecular features, I think if you actually do find that the patient has a potential underlying genetic FSGS, so the patient has like a call4 mutation, or like a TRPC6 mutation or something, in addition to maybe developing an antinephrin antibody, that would probably portend a poor outcome. But in terms of more specific, more granular, complex genetic assays, I'm not sure.
Yeah. So Dr. Zuckerman, there was another question that came in, and maybe you can answer that link to this one. I mean, in some capacity, differentiating between primary and secondary. I mean, you mentioned the genetic already, right? Because that just goes a different route. But how well can we differentiate based on a biopsy between primary and secondary causes?
Yeah, I mean, it always depends on the clinical presentation. I think if the patient is and I'm always, this is why I need this information when I read my biopsies, is that if it's really bona fide nephrotic syndrome, albumin is low, they have nephrotic range proteinuria, they have edema, and then on the biopsy, you have whatever pattern of injury you have by light microscopy, but you have more than 80% foot process effacement. So essentially complete foot process effacement and I should have emphasized this before, in a well-preserved glomerulus, so not ischemic, not involved by sclerosis, so an otherwise normal-looking glomerulus other than the podocytes. That pretty much, that's essentially you're dealing with a primary FSGS until, unless they really don't respond or they also have diabetes or they have something else in the biopsy that really makes you concerned for a secondary etiology. Now, if they have segmental foot process effacement, and they're subnephrotic, that's not primary FSGS, that's secondary FSGS, or genetic FSGS. And occasionally you do have sort of borderline overlapping cases. Like I have had situations where it's probably obesity-related glomerulopathy, but the glomerulus I had just had extensive foot process effacement. And then I had to go and, well, let me look, I only had one glomerulus in the EM tissue. I went and dug out some glomeruli from the paraffin block to sort of get a better sense. If I look at multiple glomeruli now, and frequently I'll find that the foot process effacement is actually patchy. So sometimes you have to look a little bit harder as a pathologist. And then some cases are just going to be challenging where maybe there's 60%, 70% foot process effacement. Maybe the proteinuria is sort of undulated a little bit. Maybe they had a spontaneous remission, or they're just, or for whatever reason, not a partial, immunologic response or whatever. And you're just not seeing the full phenotype. There will be cases that it's going to be hard to tell. Or again, you have a situation where maybe you have a lot of background chronic changes, you have severe arteriosclerosis, you maybe have some significant diabetic changes, and then it really becomes much harder to interpret the foot process effacement where you have other etiologies which may be injuring the foot processes. And that's really most difficult in the setting of diabetes, where if you have like nodular diabetic glomerulopathy, you can see quite a bit of foot process effacement. And then it's really hard to know if there's something superimposed there or not.
Yeah. So, another follow-up question, we have discussed that a fair bit, is, what communication do you want, at what level, and how frequently from the nephrologist? And, UCLA might be a bit different, right? We have a very open line. You text me when you find something, I text you, right? So that's as good a communication we can get. But in general, how can we help the pathologist, help us?
Sure. I think as much information as you can give us sort of up front with the biopsy is very helpful. Even like what's your differential? What are you concerned about? For any diagnosis is really helpful because there's some hundreds of diagnoses you can make on a kidney biopsy, some of which are extremely subtle, and most renal pathologists are pretty detail-oriented, kind of crazy people. So we'll usually find it, but sometimes if there's something you really want to rule out, that can be very helpful to us. But what I find is often missing. I don't know about the edema. I don't know the albumin level. That's information that I really want to know for podocytopathy. Other things, what's the patient's BMI? I think these days is very, very helpful to know. The tempo and severity of the proteinuria at minimum. Any prior history of diseases. Have they been treated with anything prior to the biopsy can really affect the interpretation of the foot processes. So if I have someone that says, hey, the proteinuria is 2.5 grams, or they are nephrotic, but they have started steroids a week ago, then the foot process effacement may not be reliable anymore. So this is all information that I would need to know. But really, I would recommend you try to have anytime you order a biopsy on a patient, have a conversation with a pathologist in some form. I think it will only help you. And sometimes it's just like, yeah, it was just diabetes, and then you can say, is there anything else you're worried about here? And we'll say, no, it's just like diabetes. But I think in most situations, having that conversation is really useful. Because I can just speak to, I have a case right now, I'm doing a second opinion review for a patient with what looks to be primary FSGS, but essentially was just the top line diagnosis on the report was FSGS with no comment. And there's been quite a delay in the patient's care despite having, it's noted there's extensive foot process effacement in the report and all that. But for me, I would have already, I don't treat patients, but if that were me, I'd wish someone had already started treatment on me. And I think, if that information was there, and again, I think some pathologists we're all a little bit hesitant to sometimes make full clinical pathologic diagnoses because what we know about the patient is sometimes it's only filtered through the nephrologist or from a clinic note. And we may not see the actual lab values. So we're always a little uncomfortable to label a patient with something that they may not actually have because we can't verify the information. So I'm not judging that pathologist, but then I think it really is really up to the nephrologist to say, hey, this just says FSGS, is primary, is the secondary, and have that conversation with the pathologist to sort of, and then say, hey, how do you think you would manage that patient? And to be fair, like we don't manage patients, but that at least helps me say, hey, I can say something like, this is not a patient that I think is where immunosuppression is going to be helpful. I feel comfortable having that discussion, but I'm not going to say, oh, this is going to be rituximab versus, a corticosteroid type discussion. That I'm not going to be able to do.
Yeah. No, but I think, Dr. Zuckerman, I mean, the cases that we have had together, I think your input has been very, very important and critical in the treatment that we decide. And I think that's what this question was trying to get at, directly or indirectly, about, immunosuppressive and stuff. So that's very, very helpful. Thank you, Dr. Zuckerman. I think there are a few more questions as we scroll down.
Let's see, increased evidence of complement system in several glomerular diseases. Do you know if there's such data from renal changes in FSGS? I don't know right off the top of my head. I mean, I'm sure there's, there was just a paper that came out of the Mayo Clinic doing sort of mass spec on FSGS minimal change and looking at complement, and I think it was fairly similar. I'm not remembering the results exactly, so I think it's something people are interested in. It's not as clear, I think, as with other disorders such as IgA, or membranous, where actually you see the complement in the biopsy in a specific fashion. We certainly see like C1q and C3 along with that IgM I showed you kind of get trapped in the segments of sclerosis, but that seems to just be plasma protein trapping. My opinion is that's not evidence of a disease, like that's not a pathogenic thing causing the sclerosis. It's coming from the sclerosis. But I'll put out a provocative idea here, is that regardless of the glomerular injury, what you see is you get progressive tubular scarring is increased deposition of C3 on glomerular basement membranes. On tubular basement membranes. And I think there's probably a significant amount of complement activation that may be driving progressive chronic kidney disease due to any cause. And I would argue that complement inhibition might be interesting just as a general protective therapy, in the setting of chronic kidney disease. But again, that's very, I don't have a lot of data to support that. I just think it's something interesting to think about. But in terms of actually, having a patient with minimal change or FSGS and sort of turning to a complement inhibitor as kind of as a therapy right now, I don't think there's a lot of data there, but it's not in the same way as we have in sort of the immune complex or truly complement mediated diseases. But there's people out there like Tony Chang, who's a renal pathologist from Chicago, that believes, he's very much into complement abnormalities and believes that, maybe minimal change in FSGS, it's actually complement that's driving all of it. But I think that's a very provocative idea without a lot of data.
Yeah. Yep. Thank you. And there was one more question right at top is, from a pathology perspective, what are the most common diagnostic pitfalls that can lead to under or over diagnosis of FSGS on kidney biopsy?
Diagnostic pitfalls under and over. So certainly sampling is a big issue. Over the last 2 decades or so, as nephrology has sort of ceded control of the renal biopsy to interventional radiology, what we've seen, and there's a nice study from Arcana Labs a few years ago, is this increase of inadequate biopsies from like 5% pushing like 15-20%. And this is sort of community outpatient. I mean, these are at least at UCLA, we have on-site adequacy. We have really excellent radiologists, so our adequacy rates are extremely high. But I get biopsies from all over California, and there's other centers that are not so good. And so either if the biopsy is inadequate, so we can't make a diagnosis, or we have too few glomeruli to maybe exclude a lesion of FSGS, although I've sort of already given my opinion on the value of finding that lesion. But certainly for having glomeruli, well-preserved glomeruli for electron microscopy and immunofluorescence is extremely important. And if you have very few glomeruli, they're subcapsular, they look very sad and ischemic. or the only glomeruli you have for EM are involved by segmental sclerosis, that can make it very challenging to know if you're dealing with a primary or secondary FSGS. And so, the sampling is really important, and getting good tissue, I think, in any situation, but especially for podocytopathies, because the EM is so critical. So getting good EM tissue. Overdiagnosis, I would say that's the situation where we probably, myself and the nephrologist needed to have a better conversation. So, for example, where mistakes happen is when the biopsy is near normal. And especially with like the radar study data and people doing biopsies for very low-grade proteinuria these days, I'm seeing probably, not too many, but maybe a few more kind of essentially normal-looking biopsies. And it's hard. How do you top line that biopsy? Do you say minimal changes? Do you say no pathologic abnormality? And I think that could be overinterpreted as minimal change disease. And then the patient gets immunosuppression for 0.3 grams of protein. So I think that's where and that's a communication issue. That's not a diagnostic issue. And then the other situation would just be kind of the example I gave of sort of just giving a pattern of injury FSGS without any sort of other discussion, or either over phone or in the report, as to at least speculating on the etiology or providing a differential diagnosis to sort of help kind of guide management, where a patient with a probable secondary or genetic FSGS ended up on immunosuppression because it sort of the diagnosis in everyone's mind was FSGS, but there wasn't sort of that careful sort of teasing out of, well, what's really driving that FSGS? And there's this knee-jerk reaction to sort of start immunosuppression. So that would be maybe the sort of over-diagnosis situations I can think about.
Great. And then one last question that just came to me, actually texted by one of my colleagues, is about the podocyte loss and what we call podocyturia, the podocytes ending up in. How are those detected in the urine?
I know I don't think it's a clinical test at the moment. I know people do that. I think that's challenging because the urine, it's the podocytes, they're falling off, they're dying, and then they may just be undergoing autolysis and necrosis in the urine. So
there's so few, it has to be, there's so few cells. It's not
right. So I'm sure you can do it, and I know experimentally I've seen this done in papers. So I think that's an interesting thing to look for, but I don't know how you would, if there's a way to sort of do it in a reliable way to make it into a useful clinical test. Yeah. But again, I don't have experience with that directly, so that's the most I can speak to it.
No, this is fantastic, Dr. Zuckerman. I think we can just see from the comments, the questions. Thank you so much. I do want to reemphasize the importance of pathology and pathologist in the outcomes. And if you have a great pathologist like we have in Dr. Zuckerman, I think it has a very significant impact on the outcome for patients. And we have seen that. So with that, I'm going to hand it over back to our Bruin Beans so they can close it off. But thank you so much, Dr. Zuckerman. And we'll be seeing you soon, for our IGAN conference. Thank you very much.
Yeah, thanks for having me.
Thank you.